mine are going to be relatively easy, my cases. So this is almost like a show and tell type of lecture. I'm going to talk about AP radiograph of the ankle. I think it's nice to go back to x-rays, as Ali has shown us, and try and figure out stuff based on the x-rays and then correlate them with other more sophisticated imaging modalities. So basically the focus of the talk, I'm going to just very briefly review some normal and abnormal easy anatomy of the AP of the view of the ankle. And then I'm going to go to more difficult cases and kind of teach us how to look a little bit more carefully. So in many instances, when we see those, I'm going to show you quite a few abnormalities. When we see those abnormalities, if we miss them on the AP radiograph of the ankle, that's it. If we don't get other imaging modalities, or if we don't get x-rays of the foot, we may miss them. So that's one of the impetus for this lecture. So my point is, this is not going to be very hard. It's going to be more challenging than hard, and we need to know it. So again, I'm not going to talk about easy fractures, right? I'm just going to talk a few seconds on the syndesmotic ligaments. So you need to look at the AP and actually at the ankle mortise view to review the syndesmotic and the medial and the deltoid. So for the syndesmotic, we measure it 1 centimeter above, and we measure the distance here. I don't know why I lost one of the lines, but the line here, the distance between this sclerotic line of the fibula and of the tibia and of the, are you seeing my, yeah, so this line here, and then you always get a little bit of a sclerotic line in the tibia, which is probably the floor of the groove, should be about 6 millimeters. You'll see in the literature, some people will say 4 millimeters, some people will say 5 millimeters. I think if you use 6 millimeters, you're safe. So that is, when this is larger than 6 millimeters, you have a syndesmotic ligamentous injury. And when you look at the deltoid, you measure the deltoid about 0.5 centimeters from the tibial profile, and that should be about 4 millimeters. The measurement, I don't know what happened here, but my animation kind of got screwed. So this should be about 4 millimeters. And then the other thing that we talk about is we talk about the overlap. And the overlap on the AP between the tibia and the fibula, again, you'll see different things in the literature. I think if you use 6 millimeters, you'll be safe. You have to remember, however, that the AP is a little bit less reliable, and what you need to look is at the ankle mortise. And my topic here is not ankle mortise. I'm not going to be talking about ankle mortise. But ankle mortise, if you don't see any overlap on the ankle mortise, you have to have syndesmotic ligamentous injury. Okay. So this is an obvious case of a fibula fracture, right? You don't need me to tell you that. But in reality, you don't just have a fibula fracture. You also have a tear of the syndesmotic ligaments, and you see the widening here compared to the normal side here. And you need to really measure it, right? So if you have increased space here, that means syndesmotic ligamentous injury. Okay. And this is, again, another obvious case, right? Here you have a distal fibula fracture. You have widening. You can have lack of overlap, complete lack of overlap. So no doubt you have a tear here of the syndesmosis, and you also have a tear of the deltoid ligaments. Okay. So now moving on to really the focus of this lecture, which is the more subtle findings that you should be looking for. And I just drew for you kind of, the calcaneus is actually more complicated than the way I drew here. But basically, these are kind of the shadows that we need to be looking at when we look at an AP of the ankle. And I'm going to divide it into lateral ankle pain and medial ankle pain. So the first case. What is the abnormality here? And that's not so subtle once you know it. So basically what you have here is flat foot deformity. You're seeing flat slanting of the lateral aspect of the tail of the calcaneus, and you also see something maybe because we put it on the, something happened to my animation, so I apologize about that. But you also see abutment between between the calcaneus and the fibula. And what's the significance of that? That you probably have extra-articular impingement. And extra-articular impingement is something that is associated with flat foot deformity. Here is the lateral view, and you can see that patient is flat. Here is again the slanting. And when you think about extra-articular impingement, you usually have normal space between the talus and the calcaneus. The calcaneus is located right inferior to the talus here, and you have nice space between the calcaneus and the fibula. When you have loss of the medial structures that support the longitudinal arch, you're going to have this thing here. And then you're going to have impingement between the talus and between the talus and the calcaneus, and between the calcaneus and fibula. That's extra-articular impingement. And this is back to that same patient. So this is an 83. Now I can tell you the history. 83-year-old with rheumatoid arthritis, posterior tibial tendon rupture, and extra-articular impingement, or in this particular case, calcaneal fibular impingement. Notice where my marker is. Even though this patient has PTT tear, you'd think he would hurt medially, but he actually hurts laterally. And not only that, we're seeing edema in this area here, and there is, on the fluid-sensitive images, you can see edema here. Again, notice where the marker here, the marker is lateral. The calcaneus is abutting against the fibula. The fibula is weight-bearing, and you're having pain laterally, even though this patient has medial abnormalities. So something to remember when you're seeing these plain radiographs, if you see lateral slanting of the calcaneus, think about extra-articular impingement. And this is another patient with slanting laterally here, and you can have fibula stress fractures. The fibula is not meant to be weight-bearing. The fibula is not meant to abut against the calcaneus. It's a small bone. So if you have the calcaneus pushing against it, you can have fibula stress fractures. So this is one of the complications of flat foot deformity. Okay, going to the next case, and I'm starting with easy. So I'm sure you guys see the fracture, right? So we have a tiny little fracture here, right? And you could say, okay, big deal. It's a tiny little fracture, who cares? But this fracture is very important, and you can have a clue here, seeing all this soft tissue swelling. Now, this soft tissue swelling could be just soft tissue swelling related to a fracture, but it could also be related to what sits there. So what's this there? The peroneal tendons. Peroneal tendons descend right here. If you have a fracture right here, that's the attachment of superior peroneal retinaculum. You can have dislocations of the peroneal tendons. So these are actually peroneal tendons that are laterally dislocated. And just to show you a little bit the normal anatomy, the superior peroneal retinaculum holds the peroneal tendons in place behind the distal fibula in the retromalleolar root. This is superior peroneal retinaculum. You have tearing of the superior peroneal retinaculum, you allow your peroneal tendons to dislocate anteriorly. So just to reemphasize, you see a tiny little fracture, your mind should be thinking, well, this is not just a tiny little fracture. This may reflect peroneal tendon dislocation. And the superior peroneal retinaculum tears usually with dorsiflexion injuries. You get violent contraction of the peroneal tendons. Was initially described with ski injuries when you had the old boots where your foot was not released out of the boot if you fell forward. And you don't need to really know this classification. You just need to know that these are probably the most common. You have a tear either here with a small avulsion fracture, or you can have stripping of the superior peroneal retinaculum, allowing the peroneal tendons to dislocate. So this is a case that was given me by Dr. Jin Su, and this is much more obvious. You have here a big fracture fragment, right? You see this fracture fragment, you think superior peroneal retinacular injury, you think peroneal tendon dislocation. And indeed, here it is, the fracture on the CAT scan, and here is the MRI, and we see dislocation of the peroneal tendons. Same thing by the way, when you see it medially. If you see a medial avulsion fracture, and I'm going to ask here, I'm not going to be embarrassed. I don't have an example of it, but if you see an avulsion fracture medially, think about posterior tibial tendon dislocation. Okay, so here is another tiny little fracture fragment here, and by now you know it. Again, you have all this soft tissue swelling. Now this pain is for 2 years. He's had it for 2 years. He's had an avulsion of the superior peroneal retinaculum associated with flat foot deformity. Here is the superior peroneal retinaculum, and you see the disruption, and you see the peroneal tendons are not dislocated, but they're subluxed. They're probably coming in and out, back and forth. That can predispose to tearing also of the peroneal tendons. And this is another patient, flat foot deformity, tear of the superior peroneal retinaculum, and dislocation of the peroneal tendons. And you could see the abutment between the calcaneus and the fibula. Okay, next case. I think this one is not as tough as Ali's cases, right? So what do we have here? So we have a fracture of the lateral process of the talus. And if you look at the normal one, you have a nice smooth appearance right here. This is lateral process of the talus. This is the opposing calcaneus. And these fractures, by the way, if they're not picked up on the AP, they're very hard to see on the lateral image. And I have here, I'll show you a few laterals. If you look, this is where the lateral process should be. And it just doesn't look right. Kind of looks irregular here, but easily missed if you don't see it on the AP view. And this is a more subtle case, right? So we see here a little bit of irregularity in this area here. This is lateral process of the talus, looking a little bit funny. When you look at it on the lateral view, actually, you see a line here, you see a line here, and there is disruption here, and loss of the normal triangulation. And I could show you here, this is a normal lateral process of talus. It has nice sharp angle compared to this one, and you have disruption of that nice straight line right here. And this patient had pain for 6 months. So they're easily missed. And I have one more, actually this is the same case. You could see what happened to him. Here is the fracture of the lateral process of the talus. There is edema, but because of that abnormal biomechanics, because of the tilt in the talus, he developed a lot of osteoarthritis medially here. And this is an easier case. Here we see it, patient 18-year-old with lateral ankle pain. Here we see much more deformity. Impossible, in my opinion, to see on the lateral radiograph, maybe here. And look at the CT. Marked fragmentation of the lateral process of the talus. So something to look at when you look at APs of the ankle, something to look at. Okay, so anyone sees the abnormality here? This is a 24-year-old, again with lateral ankle pain. Once you see it, it's not so subtle. So you actually have a fracture of the anterior process of the calcaneus, and here it is, you could see it here also. These fractures of the anterior process of the calcaneus are not the fractures that we usually talk about, the bifurcate ligament attachment. These, when you see them on the AP view, it's either the extensor digitorum brevis attachment or the dorsal calcaneal cuboid ligament. And I'm going to show you quite a few of them. Here is another patient, a big fracture fragment. And in this particular case, you actually happen to see it also on the lateral view. Many times you don't see it on the lateral view. Another patient, this was given to me by Dr. Yu, and here are 2 fracture fragments. And you could see it right here again. And I think I thought I had an oblique, but I guess not. Okay, moving on to another patient with lateral ankle pain. Anybody sees the pathology? Now this is not necessarily abnormal, this is a normal variant. and we see a very enlarged peroneal tubercle. And we do see them every once in a while. They don't have to be symptomatic, but they can be symptomatic, and this one is quite big. And notice here the normal patient, you don't have this little bump here. And I'll show you the MR in a few minutes on this patient. So what is the peroneal tubercle? It's a bony protuberance that originates from the lateral wall of the calcaneus, and it separates the brevis from the longus. Now when this thing gets big, you could see that it could push on the tendons, especially the longus, and it could be quite painful and can cause tearing. Here is a patient with a giant, you can sometimes see them on the sagittal images, giant peroneal tubercle, right? Right here. It actually looks cute in my opinion. And going back to the same patient, the 36-year-old with lateral ankle pain. Here is the x-ray again. Now look at the MR. The peroneal tubercle is pushing and laterally displacing that longus. Notice where my marker is, right where the patient's pain is. Notice that I have edema in the soft tissues. And when I look at it on the axial images, here is the tubercle, the big tubercle, pushing on the longus. And in this particular case, you don't have tearing, but you have tenosynovitis of the peroneal tendon. So here is your peroneus brevis coming, here is the tubercle, and we have tenosynovitis, as you see here. Okay, another patient, now you're smarter, also has peroneal tubercle enlargement, right? Now we are actually seeing soft tissue abnormalities here. We can almost imagine the brevis sitting here and the longus sitting here. And look at the MR. I mean, the MR, in my opinion, is unbelievable. Here is the big tubercle, marrow edema in the tubercle, a lot of soft tissue swelling, partial tearing of the brevis, partial tearing of the longus with this big peroneal tubercle. Okay, and these are the axial images on the same patient. We are not at the level of the tubercle. We're still seeing the marrow edema in the calcaneus, and we're seeing the tearing of the longus and of the brevis, and a lot of inflammation here surrounding these torn tendons. By the way, this is just a side point. When you see edema in the lateral wall of the calcaneus, it almost always is related to peroneal tendinosis rather than a fracture. So if you see lateral wall edema, calcaneal edema, think could it be peroneal tubercle hypertrophy that is causing a peroneal tendon injury. Now this is another patient, kind of similar findings, but this one already has something I taught you, right? There is lateral slanting of the calcaneus. He obviously has flat foot deformity. You can say you don't even need the lateral view to know that he has flat foot deformity. Of course, the surgeons don't need us to tell them that they have lateral, but flat foot deformity, but we are not the surgeons. But he also has this bump, right? So he has this bump here. He has weight-bearing fibula, which is bad for him, and you can almost see the bump right here. So this is a patient with flat foot deformity as well as a giant peroneal tubercle. He's forming a pseudofacet with the fibula. He's entrapping the soft tissues here. So you have the calcaneal fibula sits there and the peroneal tendon sit there. So you have extra-articular impingement as well as a hypertrophic peroneal tubercle. What do you think is going to happen to those tendons? They're going to be torn, right? And here we see this is longus with synovitis, and this is the brevis, and the brevis is markedly abnormal and has a lot of synovitis. Okay, and these are the axial images on it. So here is the big tubercle, here is markedly torn, inflamed brevis, displaced, torn, I apologize, it's going crazy, and subluxation of the peroneal tendons. They're not posterior to the fibula. I apologize about the animation. Okay, moving on. And actually, I could have shown you, I have a more subtle case of it, but I decided to spare you, so I'm showing you an easier case. And a similar case to that was shown at the ISS this year as an unknown. So anybody sees the abnormality, I think it's fairly obvious, right? You have this thing sitting here, right? It should not be here. What is it though? And this is a torn peroneus longus that has caused proximal displacement of the os peroneum. So you have a small fragment of os peroneum here, another fragment that completely proximally displaced, and you're seeing it on the AP view. They don't always have to be proximally displaced. I have a similar case where you see it on the AP view. You see a subtle change, but it's not proximally displaced on the sagittal or on the MR. And in this patient, here is the peroneus longus, and you see the retraction of the tendon, the full thickness there, and here is that fragment that we're seeing on the x-rays right here. Okay, so now moving on to medial ankle pain, and I have less examples of medial ankle pain. So this is actually not so important clinically. It's a little bit after the fact, but what we're seeing here is this area here, and anyone knows what that is? So actually that's where the superficial deltoid originates. So you know this patient must have had at one time an injury to the deltoid ligament, because you're seeing stripping here of the periosteum and cortical thickening as well as marrow edema associated with deltoid injury. And here we see it on the axial. This is the superficial deltoid coming here, and here are the ossifications. And I believe I have one more patient with similar finding. Here is the ossification, here the bump. This patient actually came complaining of a bump, and you see the stripping of the periosteum at the level of the superficial deltoid. This is superficial deltoid, which doesn't look normal right here. This is actually tibial spring component of the deltoid. You see the marrow edema here, and this is probably an acute on chronic. And how do I know this is acute on chronic? Well, first I have marrow edema, but that doesn't necessarily mean it's old, because I also have edema right here. So this patient had a recent inversion injury and also has a syndesmotic ligamentous avulsion. Going to the next case, this is a little bit more important to pick up. So I showed you superficial deltoid, and now I'm going to show you, I made it a little bit bigger, I'm going to show you deep deltoid. So this is not a common injury, I haven't seen this often, but you're seeing this ossification right here. You see this little fragment right here? And that's avulsion of the deep deltoid. The tibiotalar component of the deltoid inserts right here. This is the tibiotalar component of the deltoid, and here are the fragments. There's one fragment here, and there's another fragment right here. And by the way, notice the reactive PTT tenosynovitis or fluid in the tendon. Now this is a case that I like to show this case, even though this is an embarrassing case for me, because I missed this case. And after we saw Ali's case, I think this is easy. And not only I missed this case, I even had a history of this abnormality. So I was told that there was a talar body fracture, and I looked at it and I said, I have no idea what they're talking about. They said that that outside MRI showed the talar body fracture. And in retrospect, this is obviously should not be sitting here, right? So this is a displaced fragment of the talar body, and notice how much more fragmented this is than we can tell in the plain x-rays. You look at the lateral view, and in retrospect, you know, just too many little things happening here. And then you also have a little bit of disruption here, and on the CT, it's much more obvious, the fracture fragments and disruption here of the cortex. Another patient, and this is my last case. I think it's my last case. So this is very acute finding. This is acute finding, unfortunately, often missed. And what does this patient have here? He has this little bony protuberances medially, right? So coming from the talus, coming from the calcaneus, forming a pseudo-articulation. This is actually posterior medial extra-articular coalition. And you can kind of see it right here. So this is not a coalition at the sustentaculum tailum. This is a coalition posteriorly here. It's a posterior medial coalition. And here is the X-ray, and here is the MR of these new bone formations. It's at the level of the posterior subtalar joint, but the posterior subtalar joint is actually maintained. Another patient with the same finding, a little bit less prominent. Here is the pseudo-articulation between the bony prominence of the talus and the calcaneus. A little bit less obviously seen on the X-rays, on the lateral view. And here it is. This is all extra bone. That should not be here. All of this is extra bone. Again, it's called posterior medial extra-articular coalition, and very often missed. Normally, if you look at the sustentaculum tali, if you have middle subtalar coalition, it's going to be here. The posterior aspect of normal sustentaculum tali should be nice and smooth, and you have this ligament traversing right here. The Calcaneal ligament sits right here. Notice, by the way, the displacement of the flexihalicis and of the medial plantar nerve. Actually, I take it back. This is just normal. This is flexihal and medial plantar nerve. Now look at it in this patient here, going back to this patient with the extra-articular impingement, and you get the displacement. And we've been seeing, by the way, these cases, we've been seeing medial plantar neuritis, posterior tibial neuritis, flexihalicis longus tendon tears with these extra-articular coalitions. So basically, just to summarize what I've been showing you, I've shown you cases of flat foot deformity where you get slanting of the calcaneus. I've shown you cases of superior peroneal retinacular injury. I've shown you cases of fracture of the lateral process of the talus, which you look for here. I've shown you cases of fracture of the anterior process of calcaneus. By the way, going back to the fracture of the anterior process of the calcaneus, just a few days ago we had a case where they only got ankle films. You saw it on the ankle film. Actually, Jenny Bencardino saw the fragment, little fragment, and then she asked for foot films. If she wouldn't have asked for the foot films, it probably would have been missed. And on the foot films, you can see it. So fracture of the anterior process of the calcaneus, enlarged peroneal tubercle, and then superficial deltoid and deep deltoid you could look for here. Here's the superficial deltoid. Again, if anyone has an example of posterior tibial tendon dislocation associated with the fracture fragment here, please give me. And then you look for the talar body fractures, and you look for coalition. Thank you very much.